Hospice. I've been with Heartland to the hospice for 13 years now, so it's definitely something I enjoy. One of the reasons I wanted to get everybody together to kind of talk today is, as of December 2nd, some of the regulations changed for hospice. So I wanted to talk about kind of how does that affect the nursing home and how does that happen. There's some proposed rules that will change in your guys' regulations to match the hospice coming up in 2009. So I said, we need to have this now, and it helps get you guys a head start for coming ahead now with the new 2009 already. So we're just going to talk, some of it's a little bit of a review, so some of it I'm not going to go into great detail in, and I will try to answer any questions. If you have them, just holler, and we'll answer questions as we go also. Just on the handout, I'm not going to read through every spot to kind of talk, so if I jump around a little, that's why. I figured you guys can always go back and read this later. But just talking about the history of hospice and how hospice came to be. Way back in medieval times, the travelers and stuff would have these houses that they'd stop by. It was a long way on horseback, place to place. Well, some of those houses, as time went, as people were sick, they ended up staying at those houses to be cared for at end of life. So it kind of transitioned through that. Came over to the United States, and they kind of did under the home care Medicare benefit for a few years. Finally, in 1980, I can't remember the exact date, 1983 is what sticks in my head. Yeah, 83, they finally said, hey, we need to make a benefit for hospice. Patients need more care at the end of life as they're having their final days, final weeks, the final 6 months is what they look at and say they need more, they deserve more. So Medicare, medical assistance, all insurances, all cover that benefit for them. And so it means that somebody can come in and provide that extra care under hospice. So as we talk, we'll talk about some of that extra care and stuff too. Of course, many of you guys have heard of Elizabeth Kubler-Ross, who kind of wrote about death and dying and kind of went through those stages and really has been a basis for some of the nursing stuff we've learned through the years. And then just kind of what is hospice, and as our hospice has changed, this is the first big regulation change we've had with the COPs since 1983. So that's a lot of years with no changes, and everything else seems like has changed over time. So it's been nice with these changes. With them is going out to the patient, whether they're in their own home or the nursing home, we're going to treat them exactly the same. It doesn't matter where they're at, they still deserve that same end-of-life care. The nursing home, you guys do a fabulous job, but towards end of life, they need more care. They're more dependent on things, there's families with more questions, more concerns, all of those pieces. So it's nice to have somebody come in and help with that. Because of course Medicare doesn't say, oh, you got people that are dying, we're going to give you extra money to provide extra staff in the nursing homes, and they don't. So this is a way for them to be able to complement that, to have those nurses and that staff that's their specialty. We've got many doctors who specialize. It's kind of the same thing. It's that specialty of care again. So looking at that, and we come in, and they'll have a nurse and a social worker that come out at first, meet with them, talk about what is hospice. And so as I explain hospice, it's that extra special care. With the nurse coming out maybe once a week, maybe twice a week, maybe every day, depending on how that staff is doing. You have a home health aide that comes out. You have when they can do a bath. Even in the nursing home, we come in and we do that extra bath. We can't take over what you're normally doing. So if you're giving a bath once a week, you guys would continue that, but we would come in and do that extra bath. And that's nice to have an extra one. You may not be able to take a half hour to an hour to just do a bath and give a massage and that. Well, when our aides come out, they can do that. That's what they're there for, is to give that extra TLC for those patients. You have social work and spiritual care that come out. And they're coming out to work with your social work and spiritual care here already, but also to work with that family even more. Help family with coping and grieving and the loss and just the feelings they're coming across now that mom or dad are not doing as well and they're looking at end of life. There's a lot of denial, there's some guilt, there's a lot of different things families go through during that time. So to be able to give that extra care is really nice. They meet with the patient and do some life review and help them come to copes with what's going on, and maybe do some resolving of life issues that they've had, fears that they have. We've ran into many patients over the years, and You know, we've had ones that have had pain issues and that, and they just feel like, why is God punishing me? So to help them work through that sometimes, and just to help them work through different things, and just be there to listen. You guys know pain and symptom nurses work with, but a lot of it's got a lot of psychosocial and spiritual issues that go with it. That suffering and all of that. So it's very important to have that whole team involved with each patient to give that well-rounded care. So we have all those different team members. We may have a massage therapy come out to do a massage, which is helpful to help with some pain and anxiety with them. So there's a lot of people that come out and that are part of that. At this time that patient says, yeah, I love all these extra services, where am I at clinically at that point or physically? And that patient usually is wanting comfort cares. They don't want any aggressive treatment. A lot of times they don't want to be hospitalized. You know, they come back from their 5th hospitalization in the last 6 months and they look at you and say, please don't make me go back there. I want to stay here with people I know and care about, and have people that care about me taking care of me here. So I mean, that's definitely one way patients may bring up wanting some comfort cares. It may be that the doctor says, you know, we've tried everything. You know, we've maxed out the heart medications and all of that you're on, and there's just really nothing more that is able to be done. Or it's cancer patients, same thing with chemo, radiation, those kinds of things where it's comfort at this point. What Medicare has done with the National Hospice Organization has looked at what happens when a patient, after they've died, what they look like 6 months before that, to give us some guidelines. So we are able to help look at those patients, and those patients are coming to you and say, I really want some comfort, I just don't want to have the aggressive stuff. We can come in and look, are they meeting that criteria at that point? Sometimes they'll say, you know, there's nothing more we can do for your heart, but they're, you know, stable. They're maybe not at that criteria where they're looking at 6 months or less. So we look at those and work with you guys to do that. Work with families, work with the physicians to do that. Looking at all those different pieces with that patient. With patients, they can be full codes when they come on to hospice. That's okay. They can, we work with them, and a lot of times it's a lot of more dynamics that go into why they maybe aren't going to want to go to a DNR status. So we work with them and the family. They can still be getting maybe 1 or 2 more doses of radiation or a couple more doses of chemo, just for comfort, just for, you know, giving them that kind of last little bit to see, is it going to make a difference? So they can still have some of those treatments going, but most likely the treatments they're having is not going to extend their life past 6 months. So there's a lot of areas that it really pays to have somebody come in and do that consult and find out. And we can come in, meet with you guys, meet with families, meet with the patient, and do a consult to see, is that patient even eligible. If family says, yeah, we really want it, we can get the patient started right away if they are appropriate, if the doctor's given that order. So it's working through all of those pieces and looking at that. Of course, with all those different people coming in, we're looking at treating that full model, that, you know, the psychosocial, the physical, and the spiritual needs of the patient. And it's wherever the patient lives, so it doesn't matter if they're nursing home, assisted living, wherever they may be. It talks about the Medicare benefit and the COPs on the next slide, and we kind of talked about that a little bit already. And if you want to go into a lot of detail, it talks more about it in there. Part of the COPs, that the change that occurred is that we have to be sure to make that you guys get all of this information and that you're aware of these things with hospice as you're taking care of patients here, and that you're able to offer those benefits to your patients, because it's every patient's right to have those options brought about to them. It talks about eligibility a little bit more here, and it's really a hospice patient must have an eligibility criteria as other hospice patients. So the patient in the nursing home has to meet the same things that the patients in the homes do. So looking at that. When they come onto service, Medicare says, well, let's do some double checks here. We're going to make you do what's called recertifications. Kind of like here where you guys have your MDSs that you do it every so often. Same thing. It's just a way of making sure that everything's in place. The doctor's saying, yep, we're recertifying them. So they have 2 90-day periods, which puts us at that 6 months. And 6 months or less is typically what the diagnosis and the criteria is. So after they hit that 6 months, they said, I want you watching this even closer. So then they go to every 60 days that we have to do that research and get the physician and get everybody to say, yep, they're still meeting that criteria of 6 months or less. So that's just what that's talking about in there. Receiving hospice care, we kind of talked about that too. Anyone with a terminal diagnosis of 6 months or less. And hospice services can't be denied because of payer, those types of things. So we may have a patient, maybe they're out in their own home still, that really don't have Medicare yet, they don't have insurance, they're not qualifying for MA, they're on that borderline, they really can't afford to pay for hospice at the same time. We may take those patients on then and just cover the cost, just to be sure that they're giving and getting the care that they need. So we would just kind of eat that cost for those patients. And I think that's important, and that's one thing that I really like about working with Heartland is they recognize that every patient needs hospice no matter what with the payer, and we can give back to the community by doing those things. Of course, there's for-profit and non-for-profit hospices. Really, it's looking at how people are going to manage their money and look at what they're giving back to the community, really. And we do a lot of things to try to be able to give back. And doing a lot of our memorial funds, those types of things that we work with. We just flew one of our patients to, was it Orlando, or Georgia, Oregon, that's where it was, to say goodbye to her family. All of her family were out there, so we paid for her to fly out there. So it's something we could do to give back. A lot of times we may help, and through our funds is be able to help pay for maybe house payments they're behind on, or grocery bills, or different things like that to be able to give back to the community. We offer free bereavement services, or free education, all of those things to be able to give back to the community and to be able to provide for our patients. So really looking at that for-profit or non-for-profit, I would recommend looking at what are the benefits that agency is going to be able to bring back to your community at that time. And with being with a large company, we're able to provide some of those extra services, like if they're doing the chemo or the radiation, tube feeding, stuff like that, that we would look at. I know when we were a smaller agency, it wasn't so easy to look at those. So it's always, each hospice, they're all wonderful out there. Talk to them, see what they're going to provide for that patient at that time always. So each hospice is a little different. The other thing that we all have to offer is level of cares. We have just our routine, and that's that nurse coming in once a week, the aide coming in once a week, or just daily that they're coming in. What happens is a patient all of a sudden is in a crisis. Their pain's out of control, anxiety, something's not well controlled at that point. And it needs a skilled nurse to be able to manage that. And maybe you would have normally sent them to the hospital because you couldn't manage them. Instead, you'd call us, we'd come out, and we could provide what's called continuous care, or crisis care, which may be a nurse that may be out here from anywhere from 8 to 24 hours in a 24-hour period. So that nurse might come out in the morning and spend 3 hours here, get something under control, get the pain under control again, get a plan in place. The aide might come out, make an extra visit, and the nurse might come back out in the afternoon and spend another 3 hours, just making sure everything's in place for the evening, and maybe then the aide will come out again in the evening. That's one example where it can be broke up. One of the other examples we just had at one of the nursing homes is we had a patient who ended up with lung cancer with brain mets. So a lot of pain issues, a lot of anxiety, and so we staffed it almost 24 hours a day that we had somebody there with them, because we ended up starting her on like a sub-Q dilated pump, so that we were having a continual infusion going, that we kept having to change. We kept having to change the anxiety meds, and the patient was so anxious and up and down and couldn't follow direction that she needed one-on-one care almost. Where in the nursing home, that's not possible to have somebody in there constantly as you're caring for your other patients. So that's something under the crisis care that we can help do if we can, look at it as a medical piece that we need to cover. We can't just come in to help provide custodial care for that. It has to be a medical crisis. The other piece that they can do with a medical crisis is they could be inpatient. And general inpatient is where they have to have an RN in the building 24 hours a day to be able to put in somebody on general inpatient. And if I'm correct, you guys do not do? No, okay. So what we could do is in the hospital, if there is a nursing home that has around-the-clock RN coverage, that's something that we can do in those facilities then. One of the things that have changed, which is so nice, is the respite level of care or benefit. And that's for maybe a patient that's in their own home, family's been taking care of them, the husband really wants to go hunting and there isn't family to come in and sit with her or to be with her. Medicare will pay for 5 days, or through the hospice benefit, we pay for 5 days for the patient to come into the nursing home. They've changed the regulation. It used to be an RN around the clock that had to be in that facility. That is no longer the requirement. It just has to be a Medicare certified building. And so, and most nursing homes now qualify for that, so that's wonderful. That they can stay in their own community. You know, if their family just needs a break, then they can still come and visit. But the patient's usually very stable, it's just that family needs a break at that point. And that's where the respite. The plan is they come in for 5 days and go home. We just had a case up in Brainerd that ended up staying. You know, family realized how much better dad was doing now that he wasn't having to care for mom and being up during the night with her so much that they decided to keep them at the facility. So it may happen that way too, but the intent is they'd come for 5 days and go home again. Any questions on the level of care? Okay. One of the other things it talks about in here is the room and board. And a confusing piece that comes up with families, and we can always help clarify it, is that the hospice ends up being a pass-through. So if a patient is getting MA and MA is paying the room and board, basically what happens is our agency then talks with the biller here, finds out what that rate is, we send an invoice for the biller to sign off, yep, this is the right amount. Then we send that in to get you guys paid right away, usually within 30 to 45 days, and then we wait for MA to pay us. So it's getting that money to the building quicker, which is nice too, and then we're the pass-through. So that if they say, well, hospice is doing it, we're not actually paying the room and board, we're just that pass-through for the routine level of care. The other part of the regulations that changed is to make sure that we've always talked about patients' rights. And I'm sure you guys go through that in your regular orientation and think about that every day, is what are those patients' rights? And, you know, looking at, are they getting proper symptom management? It's their right to have that. It's not, you know, we want to be able to provide the best care. It's the right to be part of their plan of care and what's happening with that patient, and talking to them about those. They have the right to know when somebody's coming in, if it's from hospice, just like you guys do as their caregivers, and how often we're coming, what are we doing when we come. So we do an integrated care plan, which we encourage family and client and everybody to be part of, just like you guys do, and we work right with your care plan. So we don't have 2 separate care plans, it's all one care plan. So that it would show if state comes in, and that's a big hot topic over the last year or two, was state coming in and saying, do you know when the hospice is coming in? Do you know what they're doing when they come in? How does your care plan show what they're doing different than what you're already providing? So making sure that's there. And whoever does the care planning, we definitely can sit down and go through some of the integrated care planning and stuff. It talks again about just the HIPAA, the freedom from mistreatment, neglect, abuse, exercising the rights of the patients of hospice, that they can choose to be on a hospice, and to provide notice of the rights at the time of admission to hospice. They have a very nice hospice handbook that we do give to the patient and family that goes through all the patient rights, the HIPAA, all of that is included in there, so that they have that. You know, any allegations or violations or anything like that, of course, if something would come up, we'd work as a team with you guys to review that, to see how can we best handle anything. If it's our staff that have done it, we want to make sure that we're aware of it and can follow through right away and do an investigation. Questions on patient rights? Kind of a really brief synopsis, which I'm sure you guys are used to patient rights. The other part is the coordination of services. This is where it really talks about how do we work together? What do we do together? How do we communicate together? So it's always making sure that we've communicated, that we've talked about how does your facility work? Do we chart in your charts? Do you guys know that there's a tab in your chart that says hospice, and that's where we keep all of our notes. So when the nurse comes out to make a visit, they leave a copy of their note there. So you say, boy, I wonder if the nurse came this morning or not, and what happened. You can flip to that tab and there should be a note there. Same thing with the home health aid. There should be a note there for you to look at to see what's been done. They should be communicating with you when they do come here anyway, before and after they see the patient, so that they get an update before they go into patients' rooms, and then after they've seen the patient and what they found and how we need to work together with them. And then it's just the integrated resident care plan it talks more about. And then it talks about professional management. And it's basically saying, okay, somebody's got to be in charge of this pot of money that Medicare is going to give you to care for this patient. So since we have to manage that pot of money, they put the liability of the professional management onto the hospice. And that's why the room and board goes through us. That's why the meds go through us, the equipment, all of that. Because one of the benefits of hospice is anything related to their diagnosis, whether it's meds, whether it's equipment, all of that is paid for by hospice staff. So that's a nice piece. Sometimes families are paying out of pocket for some expensive medication, so that's something that helps them. Or if there's oxygen or different things like that that our patients are using, that can be costly to families. So the nice piece is that we help pick that up. And we, work together with you guys. We don't take over doing things. To me, we're still working as a partner. You guys know these patients. You know what's been going on with them. You're with them all the time. We're not. So we look at your guys' guidance on what's worked, what hasn't in the past, and what can we do to work together. The role of the hospice staff is just really coming in to be there to support you guys. And we provide the exact same care as in their own home. So if that patient's on hospice for renal cancer and they have a suprapubic catheter that needs to be changed, we'd come in and change that. That patient's maybe on services for Alzheimer's, and with that they're ending up with some urinary retention, some issues that maybe are happening, and they're having more anxiety. You do a bladder scan and it's showing that, they probably need to be cathed. You can call us, we'll come out, we can help do that catheter. If that patient can wait for us to get here. Otherwise, we can help get the orders, all of those things to help with you too. So call us, we're here to do all of those things to take some of that off your guys' plate as you're busy enough the way it is. And of course, working with you guys, it just talks more about that. Arranging the non-core services, having the different people come in, making sure that you guys know when we're coming, that our aide isn't coming at the same time that they're supposed to be in the beauty shop, that we've coordinated those things. And just the role of the nursing facility is just to become that patient's resident's primary caregiver, just as you are now. Provide the same services that you would any other time to continue to meet your Medicare and Medicaid regulations. And then notify hospice of any change of condition. That patient's not doing as well today, they're not as responsive, different things like that. Let us know, because then we can come out and help you too. So keeping us informed, we can help then get new orders, we can talk with families, those types of things for you, which is very beneficial. If a patient dies, please call us right away. If they look like they're in the dying process or once they die, we will come out and can help make phone calls. We'll spend that time with the family. Sometimes when a patient dies, that family really needs a lot of support, especially if it's in the evening or at night. You don't have a lot of staff to be able to provide some of that support. So that's when we can come out and really provide that for the families. And we let the families know that to call us, we will be out here for the time of death. And we like to be here when a patient passes or shortly after, so that we can be that support. Our medical director helps oversee the medical management of the patient. So every 14 days we get together and talk about each patient. Is there changes? Is there new needs? Is there symptom issues? But our medical director does not take over that patient's care unless that patient would say, hey, I want you to take over my care. I'm from out of the area, and so I need a physician in the area, or whatever may be going on. So then our physician, their primary physician would continue to be their physician, that we would still get the orders, all of those things, because they know that person. Or it's that physician that rounds here for you, so. Hospice services, we talked about the medications, the equipment, if there would be lab work, x-rays, anything like that, that all needs to be prior approved through us. Again, it's just like an insurance, where we need to know what's going on and overseeing, is it necessary to have those done? And what we look at, especially at end of life, nobody likes to be poked more than they have to, or to go out to this test or that. So the question I always ask the family or the physician even is, what are we going to do with the results when we get it? if we go and we draw a BUN just to see what it's at, is that really worth poking him if we're not gonna do anything about it? We look at more of the symptom management and how can we keep this patient comfortable no matter what their symptoms are looking at. So working that way, their anemia. So maybe with the hemoglobin, we're not drawing it every week. Where if they're starting to see more fatigue, short of breath, those things going by the symptoms at that point. So always they're talking with us. Patient doesn't have to be a DNR. They don't have to stop or give up on treatments. We kind of talked about that in the beginning. Transfusions, we have patients that may still go in for a transfusion, once a month, every other week, something like that, because it does give them more quality of life, and that's understandable. So that's something case by case we look at to see how that benefits that patient. And then again, coordinating services, we kind of talked about the record keeping, that we keep our notes right in your chart. When we meet every 14 days, we do an IDT update form that we send to the doctor. We also put a copy of that in your note or in your chart to show that we've talked about them as a team too, and that if there is any care plan things that were suggested, that we would bring them back to go over that with you to see what your guys' thoughts are on that. There is a nurse that's on call 24 hours a day, 7 days a week, so you can always give us a call if there's symptom or something going on. Family has questions that we can always be reached. Don't think, oh, if it's after 5, we can't get a hold of them anymore. If it's something that's not urgent, we can definitely wait till the next day, great. But if it's something, families got questions, patient's not doing well, anything like that, we want to know about it right away. The patient kind of has that change in status where something's happening, they're kind of going in that transition. I'd rather have a heads up at 6 or 7 o'clock at night than getting called at 8 or at 2 in the morning that they died and I had no idea that they had declined. So it's nice to kind of have a heads up of what's going on or what to plan for that night. And then part of the regulations, again, talk about death and dying, and that you guys are familiar with that. We can always come out and do a more in-depth in-service on death and dying. We just put a brief little bit in here that talks about the interdependent dynamics that happen with the patients. Really looking at how are they doing. It talks about the stages of dying also. And again, helping those families, helping those patients through that stages that they're going through. We have many patients that may be just angry and just almost rude to you guys, and it's not that anything you did wrong, it's just they're angry because of the diagnosis, or they're angry because they're losing their father. And so it's just helping to cope through that, and remember not to take things personally as those things are happening. We all have bad days, and sometimes families and patients have those too, and especially when they're dealing with such a big piece. They'll have the bargaining, the depression, and then maybe they'll finally come to acceptance, and then maybe they'll go back to anger. They can jump around between those stages too. So always looking at that. The emotional care of the dying patient, being supportive to those who are dying, helping the others through the time of grief. You gotta remember, some of our families have never went through anybody dying before, and so they don't know how to feel or what to do and understand how they're feeling at that point. So it's helping them cope through that. One of the really things I think are huge with the hospice especially, and we do just community bereavement also, so they don't even have to be on our hospice services to do that, and that's having, following that patient for 13 months after they've passed away, and so that we would give those cares, phone calls, visits, mailings, those types of things with the bereavement services. So if you think about a patient who maybe their spouse died and they're really having a hard time, they're kind of dying with that broken heart, just can't cope with it. Families, can't be there all the time, or they're from out of town. Linda can come out and make that extra visit with them, to work with them, to help them cope through that at that point. Linda's been with us for a long time and also is wonderful on that bereavement piece and helping people cope with that. She's got a lot of support groups in the area that she does. She's got a couple down in Annandale now. She's got some up in Brainerd. She's done some out in some of the other outlying communities. She comes out to the facility, because part of the regulations now, and we've always offered this, is to be able to provide that bereavement services to you as staff. You're the caregivers, you're just, working with that patient. You get close. You've taken care of this patient for 5-6 years. It's hard when they go. especially if this is your first step as you've worked in a facility, those kinds of things. Linda's there, that you can always call her office to reach her if you have that extra support, or a social worker, spiritual care when they're out here can do that. Linda can come out and do a group in-service and support group for the staff or for the patients. Need to switch that?
Yep.
I was waiting for the